to be here today. Thank you very much. It's my great pleasure and honor being with you. So my talk today is on endometriosis, new perspectives for an old disease. I have no conflict of interest. We will speak about the history of endometriosis, what we have now as current view on endometriosis, and that new or challenging perspectives on the disease and the conclusions at the end. So, how old is endometriosis? Endometriosis is an ancient disease, and this is a publication by Professor Cameron Nezhat and his brothers Far and Chiena about the history of endometriosis. As you can see here, this is a picture from the landmark publication by Samson in 1927, in the beginnings of the 20th century. And this is another picture from a paper or a chapter by Thomas Cullen in the 1920s about the endometriosis and its different locations. So at least endometriosis has been scientifically described nearly more than 100 years ago. If you look at this paper, the authors are describing pictures or presentations of women similar to endometriosis that have been documented even in the literature that was even earlier in the 13th and 14th century. So according to the authors, and they are world expert in endometriosis is a really ancient disease, not beginning 100 years ago only, but maybe even earlier. So we are dealing with a real old disease. So over 100 years of science and knowledge about the endometriosis, what is the information that we could have collected? We know so far that endometriosis affects nearly 2 to 10% of reproductive age women and can be up to 50% in women with pelvic pain or infertility. It requires a laparoscopy for the diagnosis, and this leads to a delay from 4 to 11 years from the onset to diagnosis. And we have some data showing that there is a delay in Egyptian people of at least 4 years. And the quality of life is impaired in most domains. The current treatments are inadequate with unacceptable side effects, and the healthcare costs are high. This is what we know so far after 100 years of research. So sometimes a change in perspective is all what it takes to see the light. So you just see something in a different perspective, then you start to see a lot of new things that you did not know before. This is Dan Brown, the author of the Da Vinci Code. He mentioned it in his novel, The Lost Symbol. So can we change the perspective, and do we see a light at the end? So what are the perspectives that we need to change? The perspective one is we move or we change from endometriosis being described as a pelvic disease to it's a chronic systemic illness. Do we have data supporting this, and why are we talking about a chronic systemic illness for a disease characterized by just implants in the pelvis? If we look at the symptoms of endometriosis, and we all know them: dysmenorrhea, dyspareunia, dyschezia, dysuria, acyclic pelvic pain, infertility. We all know the endometriosis symptoms caused by those endometriosis lesions. But look at this side. There's a coexisting systemic illnesses that are associated with endometriosis, including things in the gynecological morbidities, fibroids, adenomyosis, pain syndromes like the fibromyalgia, for example, or central sensitization, GIT conditions like the irritable bowel syndrome. These can be coexistent with endometriosis. Genitourinary symptoms like interstitial cystitis, which can happen with endometriosis, and mental health issues, depression and anxiety, immunological conditions like the rheumatoid, the lupus, etc. So why is it important to know that endometriosis is not just a pelvic disease? It's considered a chronic systemic illness, because those conditions may make the clinical presentation variable. So for example, like if you have a patient with chronic pelvic pain and she starts to have, or you think she is suffering from mental health issues like the depression or anxiety, you will always have a question: does she because she has a lot of pain, so she developed depression, or she already has depression and she's exaggerating her pain? So the point here is a lot of coexisting conditions happen with those pelvic symptoms, and you need to consider them when you are looking into the clinical presentation, and also when you are looking into the treatment, because to improve the patient quality of life, you don't have to treat those symptoms only, but also the coexistent medical conditions. It not necessarily be you that to treat the coexisting medical conditions, but adequate referrals will solve the problem. So endometriosis, and a good thing that's happening with endometriosis that you need to pay attention to is the adenomyosis. Adenomyosis is a coexistent with endometriosis, maybe in especially the deep infiltrating endometriosis, in like maybe 30% of the cases. And unless you pay attention to this, this may be a cause for the pain, even if you treat the endometriosis. So there is a lot to endometriosis than those just pelvic symptoms. It is now considered a chronic systemic illness. The question arises why those pelvic lesions would affect the distant organs. Why does a lesion in the pelvis would affect mental health, for example, or would affect other GIT, genitourinary, blah, blah, blah. So if you look at those endometriosis lesions, they are chronic inflammatory conditions. So they are releasing a lot of inflammatory mediators, cytokines, and different inflammatory things, inflammatory mediators. Those would affect the metabolism in different distant organs like the brain, like the liver, like the adipose tissue. And also the endometriotic lesions are releasing microRNAs which regulate the gene expression. So they can be released from the endometriotic lesions and then circulate in the system, the whole body system, to affect the gene expression profile in different and distant organs. This might be, and this has been proven at the research level, but now we find this as a good explanation for why the distant organs and systems are affected by endometriosis, because of those things, those mediators that are released by the endometriosis tissue. So a second perspective that we should change about endometriosis is we move from the laparoscopic visualization to the clinical diagnosis. What we have known so far for endometriosis is it's a diagnosis depending on the laparoscopic visualization of the lesions. You do laparoscopy, you see endometriosis, and you can take a biopsy and you can histopathology that this is endometriosis. But we all know or have learned a lot that endometriosis diagnosed through laparoscopy is far from perfect. Why it's far from perfect? Laparoscopy is invasive, expensive, requires special equipment and skill. It's not without risk. There is a potential risk, and it leads to a long diagnostic delay. And this is important because of all those drawbacks. It will lead to a diagnostic delay because you need to make an arrangement. It's sometimes unacceptable for the patient, and so on and so. So being the diagnosis being just invasive, you need surgery just to make a diagnosis, this will lead to long diagnostic delay. In addition, even if you do the laparoscopy, the lesion types are variable. The histology, you may pick up what you think is endometriosis and you send it to the histopathology. The pathologist responds negative. It needs also some experience with the pathologist himself, and sometimes even you may biopsy a normal peritoneum, and then the histopathologist would tell you there is microscopic endometriotic foci. So it's not very clear, it's not 100% accurate. There are difficulties with the laparoscopy, and also even if you do the laparoscopy, you cannot exactly know if she has endometriosis or not. So then we came to this changing concept, the clinical diagnosis of endometriosis. Don't wait to do the message is simple. Don't wait to do the laparoscopy. If you suspect this woman has endometriosis and complains of pelvic pain, you start to treat that with empirical treatment. You don't need to do the laparoscopy. Okay, so here the laparoscopy, the problem is the laparoscopy frequently results in prolonged diagnostic delay. So the solution here is the use of the clinical diagnostic techniques to reduce the diagnosis delay and bring more rapid relief of the patient and improve the symptoms. The diagnostic delay is bad. Why? It will lead to the woman to continue to suffer. It will lead the woman to still have the pelvic pain and the poor quality of life, and it might lead to progression of the disease. So don't wait for this laparoscopy for so long. Start the empirical treatment. And this paper is done by Hugh Taylor and his colleagues, who is a world expert in endometriosis. So how to do the clinical diagnosis? They suggested this, and this is simple. It starts by the symptoms, the history suggestive, and the clinical examination and the imaging. For the symptoms, it's all those kinds of pelvic pain. It's important to understand that pelvic pain of endometriosis should be a chronic pelvic pain. By chronic pelvic pain, we mean pain that lasts at least 6 months. The woman has been complaining of pain for at least 6 months, and she's suffering because of the pain. Simple question that you can ask: do you take analgesics for the pain? How frequently do you take those analgesics? Like it's unreasonable that a woman would be suffering from endometriosis if she's using like one pill of analgesic on the first day of the menses only. But probably some woman would tell you, yes, I'm suffering pain of endometriosis, I am taking a lot of analgesics, I'm sleeping or lying in bed throughout the menstruation because of the pain. So those type of patients that you may suspect endometriosis. So it has to be a chronic pelvic pain. And you have to depend also on the history and the imaging. The imaging can easily diagnose endometriomas, can diagnose deep infiltrating endometriosis. Yes, the peritoneal lesions and the adhesions cannot be diagnosed with endometriosis. But it's what we call a clinical diagnosis or a working diagnosis of endometriosis. So if you have a patient with chronic pelvic pain that you suspect she has endometriosis, you can just start the empirical treatment. What is the empirical treatment that we are going to mention about this? So this is the guidelines by the ISHRI in 2015. They were necessitating for the diagnosis of endometriosis that you do a laparoscopy and you take a histology. But the ISHRI itself in 2022, the new guidelines said there is no, where is that? There's no evidence of superiority of either approach. Which approach? Diagnostic laparoscopy and imaging, or imaging with empirical treatment? So if you have a woman you suspect that she has endometriosis with suffering from pelvic pain, start the image, symptoms, examination, imaging, and empirical treatment. What are the empirical treatment? The hormonal contraceptives or progesterone. Don't go beyond that. So you cannot, for example, order or you cannot prescribe GnRH agonist for a woman as empirical treatment. No, that's not empirical. You have to do laparoscopy for that. So you start the empirical treatment with the hormonal contraceptives and progesterone. If she improves, so keep her on that and don't do the laparoscope. If she does not improve, then you need to do the laparoscope to prove if she is suffering from endometriosis or something else. So this is another changing concept in endometriosis. You don't have to wait for the laparoscopic diagnosis, but you can treat empirically with oral hormonal contraceptives or with progestins for a woman with suspected endometriosis. The third perspective we need to change about endometriosis is we move from the concept of treating women when they are symptomatic to endometriosis life. What do we mean by endometriosis life? So like what we usually do is, okay, you have symptoms, we treat you, then you had the relapse of the symptoms, we treat you, and so on. No, we look at this as endometriosis life. What do we mean by endometriosis life? I'm not sure if this, I'm running. If this is very clear to you or not, but what we think here is the endometriosis is a life, so it's a life journey. You can start by doing surgery immediately and then do repeat surgery if she needs. But alternatively, a good example is you move from here to treat pain with medications throughout the woman's life, and only if she needs fertility that you do you do surgery or you do ART. The concept in this B and C is you delay the surgery. You delay the surgery and don't repeat the surgery. You delay and don't repeat the surgery. You do it only once if needed. So this example is if she is in pain, long-term medical treatment. If she needs fertility or to become pregnant, you either do surgery or do ART. But there's no this repetitive surgery. Don't do surgery repeatedly, just once if any. And this model, as you can see, there's no treatment, there's no surgery at all, the model C. So if she's in pain, you treat her for medical treatment. If she's in fertility, you treat her like if she has patent use of ovarian induction or IUI or ART. So surgery is to be done once if needed for the treatment of infertility and for pain if the medical treatment failed. So no repetitive surgery. This is an example by Charles Chaperon, this paper, who is a world leader in laparoscopic surgery. So one of the world leaders in laparoscopic surgery says, please don't do many surgeries, never repeat them, and try to minimize the use of surgery. Number 4 is from the endometriosis surgeon to a multi-center endometriosis disease or a multi-center endometriosis center. Endometriosis should be treated in a center with multiple expertise. As we have just mentioned, it's a systemic illness. It has a lot of diseases related to the GIT, the genitourinary, the mental health, blah, blah, blah. So we need to do endometriosis. There's no endometriosis surgeon. This model is no longer in the advanced world or in the developed world, but what we have is a model of multidisciplinary endometriosis center, where you can have gynecologists, where you can have pain management, nutritionists, and psychotherapists, immunologists, all those people who collaborate in treating a multiple organ or a chronic system illness, which is endometriosis. So we are moving from the endometriosis specialist or the endometriosis surgeon to a multidisciplinary endometriosis team or center. And finally, it's from a benign disorder to a disorder with associated risk of malignancy. And this is the risk of malignancies that has been associated in the ISHRI guidelines. The ovarian cancer in particular is, thank you very much. The ovarian cancer the ovarian cancer in particular, this received a lot of attention. The lifetime risk for having ovarian cancer is 1.3%. If you have endometriosis, your lifetime risk is 2.5. What does this mean? This means there is an increased risk. It's nearly double, but the whole numbers are small. So you don't need to worry or to get your patient anxious about having malignancy. It's still very benign disease. It's still essentially benign disease. And here the ISHRI guideline recommends that you don't need to screen women for endometriosis for cancer beyond the usual guidelines. So yes, there is a slight increased risk of cancer, but the risk is not that big that it needs to change your screening program for it. And as you can see here, there are other associated increased risk like the breast cancer, which rises from 12 to 13, and the thyroid cancer from 1.3 to 1.8%. Again, why this is happening, we don't know, but again, this is explained as endometriosis being a chronic systemic illness. And the conclusions, many systemic comorbidities are associated with endometriosis. The clinical diagnosis can reduce the diagnostic delay. Different treatments should be implemented for an endometriosis life management. And remember, for the life management, delay or no repetitive surgery, delay the surgery, better even not to use the surgery at all. There's been papers about the surgery increasing the endometriosis pain. And the multidisciplinary center for endometriosis treatment is the current mode or the current standard for treating the disease. And the risk of certain malignancies has been increased in endometriosis, albeit small. They are small, so no need to raise the patient excitement or anxiety about this. And thank you.
Thank you very much, Professor Essam.